Thank you for taking the time to do this with us today. I wanted to tell you, first of all, on behalf of the university, how much we appreciate the fact that you brought this over the finish line. I think everybody's very excited to listen to what the potential is and what it is that you basically you took on for quite some time in order to make this data accessible. To give everybody a context, Dr. Thomas, who has been with Independent Health for almost 7 full years and is in charge of their quality assurance programs, has probably been working on the process of bringing this to fruition for more than half of her time at Independent Health. And I also wanted to share that Dr. Thomas shared with me last week that she has taken on a new role, a very exciting opportunity with another organization. So she won't be our primary contact at Independent Health any longer, but she was still generous enough to share her time with us today. And I'm glad, Jessica, that you came to do this so that we can thank you and pat you on the back and say, oh my goodness, aren't you relieved that this is actually in the rear view window? Because I'm not joking with everybody when I say this did take years to come together. I also see Dr. Noyes has joined our session, and much of the thanks on the UB side, there she is, really goes to her. She took the lead on this, she ran with it, and she never gave up on it. The part of the reason that we're here today is because of Dr. Thomas and Dr. Noyes bringing this to fruition. So it's an exciting opportunity, and unfortunately, Jessica is going to be moving on, but we appreciate the fact that you're willing to do this today, even with your change, and we're very, very excited for you. So with that said, I will turn it over, unless Dr. Noyes, would you like to say anything before Dr. Thomas gets started?
I will let Dr. Thomas proceed with your talk. I'm here, so if there are any questions afterwards, I'm happy to answer on the UB side and logistics. So okay. Can't wait, Jessica.
Perfect.
Thank you.
And yes, so there is a little joke within here that, you know, this has taken many, many years. So the title of the presentation I have prepared for you today is really kind of nudging at the fact that this has been an epic. This has been something that we started in the world of pre-COVID times, when we were thinking about, you know, how does independent health really tap into some of the brain power in our community to make really good use of the data, the pools and pools of data that we have, so that we can find some learnings or best practices that really support both independent health and the population we serve, as well as providing really good context to the research community. So what we're going to be talking through today, and I do encourage you, this is not formal in any stretch from my perspective. So if you have questions, please feel free to interrupt and just ask. I'd like it to be as a dynamic a conversation as possible. So just a little bit about independent health for those that may not necessarily be as familiar. So we are a completely local plan. We're a nonprofit plan, which just really means that we have a very small and dedicated membership. We serve 4 different product lines. So we have lives covered in Medicare state programs, which is Medicaid. And then we have a commercial line as well as a self-funded membership as well. So altogether, we have about 400,000 members that are supported by the plan. And we do stretch across the entire 8-county catchment area of Western New York, but the primary population density is here in Erie County. So the idea that came to be started actually with our chief medical officer back in 2019. And it was really centered around a conversation that we had internally about reconstructing our data warehouse. And, you know, we started having some thoughts about, you know, well, what could we learn from this data? And then immediately heard from our informatics team that we just really didn't have the bandwidth to support studying some of these ideas and thoughts. So Dr. Billatier, who is very familiar with the way that the university works in the School of Medicine, he had an idea about reaching out to the School of Public Health, actually, and saying, you know, if we made this data available to you, would you be willing and interested in using it? So the data plus the brain power and the drive, and really another nod to Dr. Noyes's incredible fortitude around this. There was a drive and a real interest in getting this vision put into production so that we could learn a little bit about our population, as well as test some theories that we had both in the public health space and now what has grown into the School of Medicine as well. So the mutually beneficial results really from our perspective were to learn a little bit about operational efficiencies. Are there things that we just don't know about our membership, about the community of Western New York that we could use to improve the way that we deliver care? Really looking at best practices. We talk about things that as a health plan, we have lots of innovative and great ideas. The way that we manage care navigation and utilization management, transitioning folks in and out of hospitals, all of our different programs and policies around pharmacy coverage. Where do we really learn if these things are working? And then also, taking a look into segments of our membership. Are there pockets of our membership that are either costing a lot of money or are not cared for as well as they could be? Do we have any trends or uniformities where there could be improvements made to give better care to certain segments of our membership? So that was really the equation that we kind of worked through. And I think in those early days, we thought this would be really, really easy. But, as Jill kind of indicated, it took many years, and we went back and forth with our legal team, and our legal team admittedly is very conservative. So when you take a very conservative legal team and put it up against the State Research Foundation and their constraints, we had a few bumps along the way. But I am happy to finally report, and I will knock on all the wood that there is, I think we're in really good shape right now where the contracts are finally signed and sealed, and we have a process in place for creation of statements of work and review, and I'll walk through that process with you all in just a second. But, it really has been a very long road, and I think one where we've breathed some collective sighs of relief a couple of times just to kind of get turned around. But I do believe we are in a place right now where we're ready to proceed. So just an overview of the governance and kind of what got us here. So the purpose of this process that we have developed is really to make sure that we're protecting not only our data, but the protected health information of the members that we serve. And, trying to limit the information that is shared in a way that gives you all enough information to study the things that you want to study, but being very protective of what that data could tell about an individual. So a lot of the conversation that we've had back and forth between the two organizations was really around the governance and stewardship of the data. So taking a look at each organization, as well as those of us that are working within this process to determine, do we have checkpoints? Is there a governance structure? Is there a review and an audit piece in place to make sure that risk to not only independent health, but to the university is minimized? So we took a look at a typical research process and recognized that, there were parts and components of it that do make sense in this model, but as a health plan and one that is regulated by both the state and federal government, we had to add a little bit more protection in place. And so what we wound up with was a multitude of steps that take from an idea, insert a few different checkpoints along the way, and hopefully at the end will result in really great and strong published research and findings. So on the right side of the screen, and I won't walk through all of these, but in short, the responsibilities of the academic institution here are to just really be clear about what it is that you want to study. And, we've been back and forth with a few different projects and ideas that didn't turn out to be things that we could bring to fruition, but we do have several projects that are in different points of production. So the real first thing is, as you're thinking through, what data could independent health share with me that could help to inform and advance research for me or my team, it's really to focus in on something that is very clearly defined and provides to independent health, like what you're going to do, what is your research question, and what do you expect that outcome to be. Full responsibility for obtaining IRB waiver does sit with the university. Independent health doesn't have a relationship nor can shepherd that part of the process. However, it will be a waiver. There is no, in the agreement that we have worked out, there is no PHI or PII. Everything is de-identified data, so there is no human subject research included, nor could we ever release to anybody at the university the names of the patients that are included in your target cohort. So we've had a lot of discussion back and forth about minimum necessary. Part of the steps of this process include our internal risk office, who will help define and validate minimum necessary. We ask that the entry into our data warehouse be very limited. So while there may be many folks, many researchers included on a team, we ask that there is a singular analyst who will access the IH data warehouse. And to this point, we do have a couple projects, as I said, in flight, but there is a singular analyst who is working to access that data, and that is what's most favorable to independent health. So we do ask that the research is conducted independently. If there are partners that are external to the university, we just ask that that is disclosed and that our legal team can take a look at the implications of that. This did come up once already with a team out of the School of Medicine who had a external partner at a different university, and we did have to accommodate that in the way that we wrote up the statement of work. So just always being as upfront and clear as possible, it helps to kind of mitigate any of the potential hiccups along the way. There's no time constraint here. If this takes 6 months or 6 years, it's really on your timeline. All that we do ask is at the end, when the research is concluded, that you share those findings back to independent health, and that if you are publishing the research, that independent health is not named. We've had some conversations and we can discuss on an individual basis. The preference really is to be listed as a health plan in Western New York or something that does indicate our presence but doesn't directly name the organization. So our role and responsibility here is just to really chase all of the legal and risk hoops. So we take your idea, we talk through it with our teams, and then we make sure that everything is kosher and that we're able to provide the data that you are asking for and requesting, and that the stewardship of that data is sound. We will and can coach and guide. So this is our data. We know what our data has, what we have access to, how deep back it goes. So if you are unclear about a potential project and you're trying to make a determination if you should look back 5 years or 10 years, we can definitely provide that input because certain data has limitations on how long we store it. So we are available and willing to kind of talk through some of those technical components. Once we've determined what the minimum necessary use is, we will audit that from time to time. So if it's going to take some time to build the data that's being exported, the analyst from your side would have to meet with our internal team a couple times just to make sure that what was requested is actually what's being exported. And that's really just to protect both of us. We do ask that every proposal be put in front of our internal governance team. So our governance team is a split structure of both executive and senior vice president leadership. We take a look at everything from institutional risk to financial risk, again, the safety of the data. We've had talks and conversations about the way the data has been exported. Would it potentially paint independent health in a negative light if something that you found was unfavorable? So all of those conversations and questions go in front of our governance board. And then after you've presented the project, you would step out of the virtual room and we would have an internal conversation about the validity and desire to proceed with the project. And if approved, I would get back to you with next steps there as well. So we are available. We do have several PhD folks at the organization, some with extensive research and analytics experience. So if you do want to have some support for a project or co-author a certain section of a project, we do have folks available that, you know, would be willing and interested in to support that. Again, at the outset here, just the expectation that when the findings are presented to independent health, that we would then take that and distribute the learnings as appropriate. So if things are learned about operational efficiencies or prior authorizations or practices, we would distribute those to the appropriate teams. Because, you know, if you've spent the time studying and doing this work, we want to make sure it gets into the right hands. And then we do catalog and retain all of the projects in a pretty comprehensive library. So every step of the way, every email that's sent and exchanged about each of the topics is retained within our internal library. So as far as accountability, we've talked through a little bit of this already. So a lot of it is around, you know, just keeping in touch, reviews and audits, ensuring adherence to the proposal, making sure that findings are shared at the end. We do ask that, I guess what I would call a best idea timeline be presented at the forefront, just so that we know if this is something where we're going to have the analyst working on our network for 6 months or 12 months, just so that we have an idea to capture the risk that the organization is facing in that. So let's talk about the data. So as a health plan, we have a large amount of data. We have a data lake, a data stream, a data pit. There's all sorts of different ways that we hold and classify our data, but in 4 real large categories here. So first is medical claims. So we keep 10 years of data plus the current year. So right now we're back to 2014 plus 2024. We do maintain that data in full capacity. So we have hospital claims, facility claims, private office claims. It doesn't, you know, where the claim originates does not have any impact on how long it is stored. So all medical claims are kept 10 years. We do have behavioral health claims for Medicaid members specifically. So when you're thinking about what your target population could be, we do ask that, you know, you have some consideration to line of business. So Medicaid, Medicare, commercially funded. Because Medicaid does have at times our state population different parameters and different requirements. Also, systems have changed over the years. So if you were perhaps studying something in the behavioral health space that was focusing on our state members, we don't go back 10 years there. We only go back to 2016. So there are oftentimes a few nuances to the types of claims that we have stored. Pharmacy claims, much like medical, we keep for 10 years plus current. Now, just a quick note that not all of our plans have pharmacy coverage. So there might be some disconnect between a person who is medically insured versus pharmacologically insured. And additionally, Medicaid carved out pharmacy in 2023. So the state took back into a fee-for-service model all of the Medicaid coverage for pharmacy in 23. So there would be a limitation there as well. Additionally, independent health has grown and maintains a disease registry. So every month we go through and farm and glean claims based on specific diseases. And I do have a few listed out here, but overall, I believe there's 40 plus diseases that are monitored through the disease registry. And that was created in 2017. So we can go back about 7 years on that as well, really giving a trajectory of disease care. So specifically, if you were focusing on something like hypertension and you wanted to get a little bit deeper into the information and what would potentially include demographics and some HRA responses and clinical care lab values, all of that would be sourced from our disease registry. We additionally have some what we call dimension or care coordination tables, and the data that's available here in large part it goes back 3.5 years. So procedure codes, DRGs, which are disease groupings, revenue-based codes, as well as all lab data and vaccines. Those are sourced and have a look back to about 3.5 years. I often advise if there's information that you are looking to glean from lab data or vaccines, our repository might not be the best source for you. I will just give a little bit of a nod to HealthyLink. HealthyLink does have an extensive pool of data as well. They also have a research committee that does very much what we do and what we have built here. But it would be on a different level. And there's a few different checkpoints that you would have to go through in working with HealthyLink. Sometimes there is a cost to doing that. So just something to keep in mind that if you can't necessarily define the criteria as you had hoped with independent health, there is potential to seek that out through HealthyLink as well. And new in 2024, we are just starting to build out care coordination tables around social determinants of health. So as things are changing in the landscape of care delivery and, providers and systems and community-based organizations are starting to do SDOH screenings, we're starting to capture and house that data as well. Right now, our primary focus is on food insecurity, housing stability, and transportation access. So all of those members who have responded to a screening with an indication of a need in any one of those three domains, that data is captured. And then we can apply it to things like our disease registry or our risk stratification report. So what that helps to inform is, does somebody with CKD or congestive heart failure also have some of these social challenges, and how is that affecting their trajectory of care? So we have added that indicator as well. And I saw there's a little flag. Is there a question? I don't want to navigate away, Jill.
I'm sorry, I had to find it myself. Just a positive comment, saying that this is a remarkable opportunity for research.
Yeah. Yeah, and it's a remarkable opportunity for us as well, because as I mentioned, our informatics team, we do have a lot of smart folks, but they really do have a responsibility to run our business. So some of the things that we would love to be able to gain insight into, we just don't have the capacity and the bandwidth to support. So this is mutually beneficial. And it's something that, we have really been excited about the potential for many years. So. All right, so just really quick, what's in a claim? So if you're not quite familiar with a claim, there's a few different things that we can learn from it. First is through a CPT code, which is the current procedural terminology. This is what did the doctor do? What did the provider do? And those codes can tell us what a service was, how long or how intensive the service was, where that service took place. So you can tell the difference between an urgent care visit versus a hospitalization versus something that could have taken place in a relaxed outpatient setting. DRGs, so we have an access with a partner and a vendor called Milliman, where we have a database that gives us much more substantive and categorized information. So when you look at somebody's hospital stay, those are actually grouped into categories that we can learn on based on a diagnosis. So somebody who may have gone to the emergency room that turned into an inpatient stay for diabetes, that would fold up into a DRG that would give us a really deep look at all of the care that that patient received during that stay. So you're not trying to piece together individual procedure codes. Everything kind of rolls up into this big comprehensive group. ICD-10 codes, or a few years back, what would have been an ICD-9 code, gives an indication of what a diagnosis is. And again, severity can be found within the diagnosis code, classification of a disease or a acute symptom. So what you can do is you can base a look or a query onto an ICD code. You can take a look at somebody who may have COPD and then, dig in from there. So everybody that has an ICD-10 code for COPD with this classification, you can look back 7-8 years and start to determine what kind of criteria you wanted to look at and what those variables would be. So oftentimes starting with ICD codes and working backwards is really the easiest way to wade through the data. And just a quick note, I do see there's a few questions. As far as medication is concerned, just as a note, our records and our data really only takes a look at outpatient pharmaceutical claims, so things that are administered within a hospital setting or an inpatient setting are much more difficult to discern without having access to medical records. I don't want to navigate. Jill, are you able to read the questions for
I
me? I don't
can.
want to lose my
Yeah.
screen. Thank you.
Sure. So there's another one that says, who owns the Medicaid data and does a separate approval need to be sought for Medicaid for those data points?
So Independent Health is the owner of our data, although it is shared and exchanged at the state does not have ownership so there is not a secondary requirement to obtain approval from the state. So we handle that all through our own contract with New York State. But to that point, there is certain information that cannot be shared. So the state does classify or shield data. We mask data. So certain things related to pregnancy, substance use. There are a few different criteria that would need to be purged from any data shared.
Excellent. Other questions in the chat? If anybody would like to ask Dr. Thomas a question, feel free to raise your hand and I can call on people just to keep some order. Bob Waller, School of Pharmacy.
How you doing?
Hi.
You had mentioned before Healthy Link, and we've been working with the Healthy Link data set quite a bit. I'm just curious, some of the things that we don't have, obviously I'm interested in medications. We don't have on the Healthy Link side the dispensing data. However, you do.
Mm-hmm.
Is there any talk or any crosswalk between the two data sets? Or could that be created?
So you could absolutely develop a project and a statement of work to access that through our database. But as far as us working in this capacity with Healthy Link, no, we've not formalized that relationship. I do sit on the research committee for Healthy Link. So oftentimes when projects are being discussed that have come to them, I will advise a little bit based on the things that we have access to. So I think in part it would likely be two separate access points.
Okay, thank you.
Yeah.
We have a question from Dr. Michael Oldani, who recently came to UB. He's now the director of the Interprofessional Education Program with us. Michael?
Hey, thanks, Jill. I really enjoyed the talk. I came on a little late. I just had a really basic question. In the interprofessional space, what we're looking to do is track learners, and that could be students or clinicians, and then follow their impact on outcomes, patient outcomes. And I'm wondering, with the data that Independent Health tracks and puts together, I can follow up with you, if you see that as a possibility. So in other words, if these learners had an interprofessional intervention that we could track, could we continue following those providers as they treat patients to, say, look at like hospital readmission rates? That's a common one.
Yeah. So I think it depends on how that would be developed. So if you're looking at Dr. Smith, for example, in the patient panel that Dr. Smith has treated, absolutely, because we can de-identify that at the source. If you had, let's say, a list of these 70 patients that Dr. Smith saw and you wanted to take a look at it that way, that we can't do. So our legal team and risk team are they're very critical of the way it's presented so that we are not looking at specific patient or targeted patients. So we couldn't evaluate a cohort of patients, but if you wanted to take it in a direction where we were looking through the providers panel, as long as we're able to de-identify that, we'd have to talk through the way it was positioned, but it is possible.
Okay, that's really helpful. Thank you.
Yeah, and just as another clarification, we could never disclose back to you, like if there were 100 people, 100 patients that were part of that, who the 50 were that had a different outcome. We could never connect back any patient information.
I see. No, that makes sense. Yeah, I will follow up.
Okay, that's good.
Thank you. It's really helpful. Thank you.
Jessica, next on my screen, I have, excuse me, Dr. Nancy Nielsen, who is Senior Associate Dean for Health Policy at UB.
Hi, Jessica, and
Hi.
I'm also a whole long time ago was Chief Medical Officer at Independent Health. So I love Independent Health, just so you know. I have two, I think, probably easy questions, and one that is actually very important, but may be a little difficult. The easy question is, you talked about collecting the social determinants of health this year. Are you doing that on all members,
Yeah.
not just the Medicaid waiver members?
Correct.
Okay, great. And then I want to try to understand a little bit better. You said when you were talking about types of data and referring to pharmacy claims, you said that Medicaid carved out their pharmacy in 2023. You then said that later on, Independent Health owns its own Medicaid data, but the state restricts some actually very, very important things.
Yeah.
But anyway, I don't understand the carve out of the pharmacy
Sure.
Medicaid, Independent Health owning your own Medicaid data. And then I'll get to the tough question after you answer that one.
Okay. So the specific to pharmacy, so pharmacy claims, I believe it was July of 2023, transitioned away from being managed Medicaid to fee for service. So the pharmacies, like you had a prescription of amoxicillin, it's billed directly to the state. There's no claim that comes to Independent Health. So the state manages post July 23 their own claims in a fee-for-service landscape. So we do get quarterly updates just around drug trends, but as far as being able to see with regularity the claims, those are outside of the managed care space now.
Okay, that's helpful. Okay, now the tough one. Okay.
Sure.
And let me, I'm not trying to cause trouble. I'm
No.
trying to anticipate trouble. And the lead in is, years ago, the makers of branded L-thyroxine commissioned a study done by pharmacists out in California looking to see if that versus generic L-thyroxine were equivalent. When they found out they were equivalent, the pharmaceutical company refused to let the data be published. So I think everybody is worried about control, finding things that might make Independent Health look bad.
Yep.
I don't think, let me give you an example. Suppose Independent Health were to institute a novel intervention to try to help patients. And that is studied. And then as one studies it, it turns out that that intervention actually worsened the situation, didn't improve it. You wouldn't know that at the time the proposal was being proposed to Independent Health. Would the lawyers at IH require that, if Independent Health isn't named, it would never be made public. But you understand what I'm trying to say.
I do. Yep. And we talked about it ad nauseum. So it's not a difficult question in that regard. So part of, and what I'll show you in a couple of slides here, is we do take that what we would call reputational risk into consideration as well. So part of the step process when, let's say you were to bring a proposed idea in front of our governance board, that would be something that was discussed. Maybe a realistic example of that is we've put into place some prior authorization and step therapy requirements around the use of Ozempic, Wegovy, and those things, the GLP-1s for weight loss. We did that because our best practice informed that as, you know, what the industry should be doing in order to have fair and equitable access for those that qualify and would require the medication. However, if it were to be found that, let's say, our prior authorization or step therapy requirements were disfavorable or maybe a little too vigorous or maybe not vigorous enough, we do understand that risk as being part of entering into this agreement. And the way that we account for that is both in that review initially. So those things would be talked about, you know, to say, well, Dr. Nielsen, if it were to show this, you know, would you give us a heads up? We have been very clear that despite what the research shows, it would not, we don't have, there is no step in the process to put a stop on any publication or to kill your research midstream if it were looking unfavorable. We do, and that is part of the reason why we ask good outcome, indifferent or bad. We ask to just be anonymous in any write-up or publication for that reason.
Terrific. Thank you so much. I'm sorry
Okay.
you're leaving.
Just going to a national landscape. So I took a position with NCQA, the National Center for Quality Assurance. So spreading my wings a little bit.
Jessica, we have a question from Dr. Lackner, who is a professor in the Department of Medicine, and he heads up their behavioral medicine programs as chief.
Oh.
Dr. Lackner?
Thanks, Jill. I am an investigator on one of the early stage projects, and I need to first thank Dr. Thomas and Dr. Noyes and their team for this initiative. Our project started in 2019, and it has been a very challenging at times process, and I can't thank people enough. I've been fairly continuously funded by NIH, and one of the over the past 25 years, and I say that for no other reason than one of the challenges for us is that we don't really always understand the language of our community partners, and we don't always understand the practical, real life impact that our work does. This provides such a unique opportunity to fill that gap, and I can say that my project is the one that Dr. Thomas mentioned is involving another top 25 university, and this is an opportunity that they're salivating over. So I really think this is a wonderful opportunity to add a dimensionality to our biomedical research portfolio. Thank you.
Yeah. And thank you for your patience.
So Jessica, we have a question from Dr. Sethi, who is professor in the Department of Medicine and actually also runs the clinical research office here at UB.
Yeah, thanks. So yeah, really, Jessica and Katya, really exciting opportunity. So this is a question, two questions actually. One is to you, Jessica. Do you folks participate in the Optum research database?
No.
Okay, good. Because I've done a lot of work with several companies with the Optum database,
Yep.
Real world evidence studies. So it'd be nice to maybe take some of those questions and bring it to, we can have a kind of a larger database, national comparison versus a local comparison.
Yeah.
So that's exciting. And the other one was more actually for you and for Katya. Do we have an analyst identified? Because you said there should be only one analyst who's from our end. So I think it's more of a question for Katya.
I will leave that to Katya, yes.
Yes, so for this last 5 years, I've been paying for an analyst myself. And I can't wait until we have a centralized office in some way, so I don't have to take time and funding out of my research program. I would be thrilled that we have a capacity to address the needs of multiple investigators at the same time. So happy to discuss that. It's been on the table with CTSI and VPR's office, but we literally just signed the last data use agreement a couple of weeks ago. So this is all very, very new, but please stay tuned.
Thanks, Katya.
Jessica, Dr. Leonard, who basically headed up the regional or the Research Institute on Addictions for a bunch of years.
Hi, Jessica.
Hi.
So I have, I think I have at least two questions. So you mentioned that there was some restrictions on the Medicaid data with regard to alcohol and substance use. Can you talk a little bit about those restrictions as well as what the extent of that data is with regard to the non-Medicaid data?
So that restriction we actually apply across the board. So we do mask, SUD and alcohol and certain behavioral health disorders. So classifications, I believe schizophrenia is one of them, where that data would be withheld from any extract created. So when we obtain records, oftentimes diagnoses are masked to us as well. So in medical records, our ADT feeds that come from hospitals based off of a inpatient stay oftentimes won't have a SUD diagnosis on them. So there are some technical limitations as well as the structural limitations that prohibit us from sharing and disclosing. So we have quality programs, just for an example, that this isn't isolated to the research opportunity. So we have quality contracts in innovation incentives with our providers, as well as with some of the ACO groups in Western New York. And we do set goals and benchmarks around, the initiation and treatment for alcohol dependence or for substance use disorder treatment. But we can't give lists of who those people are in the denominators because of these restrictions. So the approach has always just been to confine to the federal guidelines. We mask and eliminate that data from any sort of eligibility, file, list, roster, or any even de-identified information that is shared externally.
Okay. So the second question is not alcohol or drug specific, but it's, as you, when you develop a question and you begin to delve into the data, it's often the case that the data leads you in a different direction.
Mm-hmm.
And I was wondering what kind of discussions you might have had around those kinds of provisions.
So if in fact the data needed to be expanded or even taken in a 180-degree, what we would ask would that a modification to a statement of work be submitted. So it would follow a bit of a truncated process. You wouldn't necessarily need to go through the governance review and all of that. But it would require some updating to some of the forms and then probably some discussion with our risk team as well as our informatics folks to make sure that the new data being requested still falls in line of scope.
Okay, great. Thank you very much.
Yeah. Okay. So the next slide just really kind of goes through the steps, and I'm happy, Jalal, that you have this and it can be shared with everyone as well. It has my contact information as well as that of our medical director over quality and PHM at the end of the presentation deck as well. But these steps are really a very simplified version of what do we do next? So the first would be to just entertain a conversation with myself and some others about your idea. We can help coach and define scope and talk about, what's in and out of bounds for us. We can be a little bit more specific about your areas of interest and what data we have. The next step would be to take a look at our data dictionary, which the School of Public Health does have and can share. You have permission to share that data dictionary as well. And it would be really defining and setting data parameters and criteria The next, and I can show you on the following slide, is we have a project assessment form, which really goes through and tries to categorize and capture some of the scope and the potential risk. We talked a little bit about that relationship risk, as well as financial, implications that could fall to the organization as well. So it does look to kind of capture all of that. I take that form and I prepare a brief to our governance team, and then we would set a date for you to come and have a conversation. We do meet weekly. It's Wednesday mornings at 8:30. So you would have a 15 to 20-minute block of time to talk over your project with that team. Sometimes there's questions, sometimes if your presentation is pretty straightforward and there doesn't seem or appear to be any risk, it could be without question. But once that conversation is had, the next step would be to formalize a statement of work, obtain and consult with the IRB. As Dr. Sethi asked, there would need to be an analyst to farm the data. As of right now, we do have a singular point of entry into our network through that analyst that Katya mentioned. We'd like to limit that as best as possible. It wouldn't be really great for us to have 50 different analysts accessing the system, but a handful, depending on department and use, is completely acceptable. That analyst would work with our informatics team to code, extract, and de-identify the data. We have very specific and very intentional steps that have been approved by both our legal team, your legal team, and then in this latest go round, all the way up to the research foundation at the state level. So we do have to make sure that we're adhering to those steps in order to make sure that we're following the letter of the data use agreement that we both have signed. We will ask for communication. There's no formal weekly touch point or anything like that, but I do exchange emails with folks on a pretty regular basis just to kind of get some insight and update onto where the project is progressing. Again, there is no expectation. There's no exchange of any finances here. There's no contract deliverables set on a deadline. It's really work at your pace, but just to please keep us updated on that progression. And then at the end, making sure that those findings are shared back with Independent Health, because we want to make sure that the data that we've provided did give you the insight that you were looking for and was helpful. And then the last slide I have here, which may look a little bit like an eye chart, depending on the size of your screen, but this is just a screen grab of the project assessment form. The red writing here are just my notes that I put on when asked by the School of Public Health for a little bit of context and what should be the answers to these questions. So what you would actually submit back to me would be less the red writing, but realistically just a statement of the project objectives, the scope, including, as I mentioned, specific aims, the most clear data methodology that you can develop at the starting point makes for easier conversations. Answering some questions about what the deliverables will be. Are you going to publish this? If so, what are you targeting? Where are you targeting to publish? Do you need any co-authorship? Are you going to present these findings? Like if something were planned to go to a conference, disclosing that here as well. And then if there is any intellectual property developed throughout the research, who will own it? And just, I do give a little nod here that there are no wrong answers. There is no expectation that if you say, UB would own the intellectual property, like that's okay. We're not asking for ownership of anything here, just making sure that everything is disclosed so there aren't any questions. We do ask for an outline of the potential benefits as well as a impact overall to Independent Health. Is there a cost benefit analysis that can be done and provided to us? If findings were to lead to optimizations in the way that we deliver business and deliver care to our members, that's helpful to get things over the finish line here as well. On the right side there, I think there's 9 different areas of potential risk, and each has an explanation. You might not have an answer for all of them, but if you could notate in each of the boxes, some answers to the questions in red, just so that will be what will lead the conversation amongst our governance team. So specifically, the major areas of concern and focus are going to be on competitive risk. Does sharing this data put us at a advantage or disadvantage, with our competitors in the market? So a lot of the insurance business is driven on the sale of that product. So we would just like to avoid anything that puts us in a negative competitive space. There is also a question around member dissatisfaction. So we want to make sure that there is no disclosure of members' data being used for academic research, which is why we're very firm on the de-identification of any data that is shared externally with the organization. And then, finally, just having asked, has this gone through the academic IRB review process? If yes, just making sure that you're giving a statement that that waiver was approved, and including a copy of that with the assessment and statement of work when they're ready. That's it. Dr. Sethi.
Yeah.
Just a quick general question. How many lives covered are we talking about? I mean, how many lives, how many individual patients over the years or at an annual basis?
Over the years, I couldn't tell you offhand, but current state about 400,000 for all lines of business. But obviously there's some variance to that year over year.
Thanks.
Sure. So, oh, I'm hearing an echo and I apologize. Jason, okay, one last question and then go ahead, Jason.
Hi, I'm Jason New. I'm an assistant professor in the Department of Epidemiology at UB. My research focuses on women's and children's health and related to environmental risk factors. So I wonder what type of data do you have for pregnant women and the new moms, and if you have also the health data of the offspring from the new moms? And a second question is, do you have information on where they live so we can link to external environmental exposure databases?
Yep. So a few things. First and foremost, maternity. I don't know if you caught when I said, or if you joined late. Maternity is one of the things that is masked by New York state law. So we can't, while a pregnancy, during the time of pregnancy, we can't share any claims data or any sort of data related to the pregnancy. And that's a protection. They're considered a protected class in our realm. However, when there are infants and you want to start to take a look at the newborn or, first 100,000 days of life, whatever that may be, we are able to do that. And in certain cases, you can correlate that back to maternal care, to the mother and what her claims and care looked like. I will say that really is only true for our commercial product, not for Medicaid, because for Medicaid, you get into a little bit of a fuzziness because members have their own ID number. They're not in the system under a family unit, so you don't have a subscriber independence. Everybody kind of has their own unique identifier, and the system just does not allow for any sort of connection between one ID and another. So you might have, and we can absolutely talk about, ins and outs and possibilities offline. But I would say kind of at first glance, yes, depending on what it was you wanted to look at, there could be some construct around that, but it probably would need to be limited to the commercial line of business. And as far as environmental data, we do have demographics that we can share. Some social determinant of health data that's just starting to come in. We do glean some data from EHRs and medical records provided to us through a direct link to health records from certain providers. So there might be some context there that could be shared. But a lot of times when you're talking about environmental and kind of some of those factors, we do internally look to imputed data more often than not.
That's exciting. Thank you.
Yeah, of course.
Dr. Thomas and Dr. Noyes, tremendous thanks from the entire team here and the many people that will be accessing this talk for the resource that you brought over the finish line. I've been sitting on the sidelines watching the two of you navigate this. We've pushed this talk off, I think, at least twice because every time that you guys thought that you were there was another legal thing to navigate. So cheers to both of you. And actually, thank you. You know, Jessica, if you can express to Dr. Bilatera, thank you so much for his vision in realizing what a tremendous opportunity this would be for both the university. And I'm sure, based on the talent that I see across the screen, what a great opportunity it's going to be for independent health as well. So Dr. Noyes, do you want to wrap things up since this is so close to you? And Jessica, when I sent Katya the message and said, did you know that Jessica is moving on?
I didn't tell her.
I sent a message and I did not call because I didn't want to hear her reaction, frankly. So we wish you well. You have been a tremendous partner, not only on this, but people don't realize what a great partner you've been on so many other things that you've helped the health sciences and the university with. We will very much miss you, but are very excited for the opportunity that you have, and cheers to them for recognizing your talents and recruiting you. So Dr. Noyes, I pass it to you.
Thank you very much, everybody. Jessica, it was fantastic to work with you on this. I hope your departure is by no way affected by this experience. And for other people on the call, I want to mention that you probably get an impression that it was very, a lot of animosity. It was actually a very collaborative process. And the reason it took so long has nothing to do with willingness to collaborate and people involved. This is a reality of data oversight and confidentiality and making sure that the two organizations can actually collaborate together. So it's a very good team, and I don't anticipate a lot of problems. But my second comment is, for all of you who've been on the call, you probably realize how complex this data are and how much information you can abstract from this claims data. And if you're not familiar with claims data, which is a byproduct of healthcare, it was never designed for research. Nobody ever envisioned that it's going to be used for research. So I encourage you to build a team that not only includes clinicians and researchers and biostatisticians, but also people who understand healthcare process, insurance operations, because again, a lot of this data is designed to facilitate operation of independent health. It's not a project that I would recommend to a student or a junior faculty or somebody on a tenure clock, because it's a tremendous investment of time. But our team has expertise. I don't know how much we can stretch further, but we are more than willing to share our knowledge on all of the steps that lead to designing a good data proposal, as Dr. Thomas was describing, because it will save time for everybody. Rather than fishing, you cannot imagine how much data out there on every single sneeze and every claim that's got rejected. So you may have a very good research question of how often claims get rejected. So think about it creatively, but let's work together and save time, because in reality, independent health research is not their mission. That's where most of our contracts has been. How do we reach our goal of UB, of advancing scholarship and research, without compromising independent health mission to provide good care and save their time and be mindful of their analysts who already have full-time and busy jobs, and work together to streamline this process. But I think we're almost there. So fingers crossed, and look forward to answering any other questions UB folks may have.
Yeah. And just as an FYI, I am here through the end of the year, and you will be left in very good hands. I will ensure it before I leave. So,
Awesome.
Thank you, Dr. Tama.
of course, thank you for the opportunity and for coordinating it all.